Hello, welcome to our last recording for Patho. Let me stop being an angel. Looks like my light was going crazy. And Sophie, my kitty cat, I think is going to make an appearance and say hello. Oh, thanks, Gretch. Okay, so this is about chapter 19, which is going to be our reproductive system disorders. And then this is going to close up the pathophysiology course. So thanks for sticking it out, and we will talk to you guys during class. So, just a little bit of a review of the male reproductive systems. Let me make this a little bit different so that we can look there. Okay, so we have testes, which is the location of the spermatogenesis or the formation, genesising of the sperm. The epididymitis, which is where the sperm mature, the vas deferens, which is where we transport the sperm to the urethra, the seminal vesicles, which is where we have secretion, which is going to be nourishing the sperm. The prostate gland is responsible for secretion in the seminal fluid to balance the pH. The Cowper glands, which are the bulbar urethral glands, these secrete alkaline mucus into the reproductive system. And then also the penis is going to be for the ejaculation of semen. So the anatomy of the male reproductive system is detailed here, and this is figure 19.1 on page 515 of your book. And so you, again, are going to have your ureter, which we talked about last week. In the urinary system, you have the surface of the urinary bladder, right? We have down here the glans penis, then you have the pubis, which would be the foreskin. You have the testes, you have the scrotum, which is like the sac around the testicle, right? And then you have the seminiferous tubules that are within the testes, the ductus deferens, so the vas, and then the urethra, the epididymis, and then the actual penis. Okay. So male hormones that we need to pay attention to are going to be FSH and LH and testosterone. So FSH is follicle stimulating hormone, and this is what's going to be initiating or starting the formation of sperm or spermatogenesis. You have the luteinizing hormone, and this is what stimulates the testosterone production. Then you also have the testosterone, and this is where we have the maturation of the sperm, the sex characteristics, protein metabolism, as well as muscle development. Talking about male reproductive system disorders, let's start out with inflammation and infections. And these two that we're going to be talking about is prostatitis and balanitis. So with prostatitis, you have a couple different categories, and you have category 1, which would be due to acute bacterial, category 2, which is chronic bacterial, category 3, which is non-bacterial, and category 4, which would be asymptomatic and inflammatory. And so this is starting to be discussed on page 518 in your book, and you can see all of those are going to be bullet pointed as well. Prostatitis, this is again on page 518. We're going to talk a little bit more about this one. Anything that you have an itis is going to be an inflammation of, and then the prefix is going to be of what it's inflamed. So prostatitis is going to be the inflammation of the prostate. And so your acute bacterial is going to be when the gland is tender and swollen, and the urine and secretions will contain bacteria. If it's non-bacterial, the urine and secretions contain large numbers of leukocytes, where if it's chronic bacterial, then the gland only is slightly enlarged. You have dysuria, frequency, as well as urgency. Acute bacterial infections are primarily caused by E. coli and sometimes Pseudomonas, Proteus, or Streptococcus faecalis. You have chronic bacterial infections, and this is related to repeated infections by E. coli. And then these are also opportunistic bacteria from the normal flora of the gut. And so E. coli, you guys know, we have in the anus, fecal material, right? And so if you don't necessarily have the best hygiene, or even if you do, sometimes things happen, right? And those can get into the wrong spot and take root and start growing, and therefore cause an infection. So the etiology, again, this is on page 518. This usually occurs in the as an ascending infection, and this will usually be with young men with UTIs, older men with prostatic hypertrophy, so like a enlarged prostate. They can also be associated with STIs and STDs, and also these can result from catheterization, right? So with the urinary cath, you're sticking it up right in up the urethra and the penis, right? And so you can have some hijackers in there that can, if it's not clean, sterile, you didn't clean the tip of the penis, etc. So sometimes it can occur from catheterization and then also through bacteremia. Signs and symptoms of both acute and chronic forms are manifested by dysuria, urinary frequency, as well as urgency. You can have, this will cause decreased urinary streams. You can have the acute form, which can include fevers and chills. It can cause lower back pain because, again, things are going to maybe build up and keep pushing up against maybe where your kidneys are, right? Like we talked about last week. You have leukocytosis, you have abdominal discomfort, you have systemic signs, which include fever and malaise. It can make you not want to eat, and then it can also cause muscle aches and pains. So, how would you treat this? Well, through for acute or chronic bacterial infections, you're going to be treating it with antibacterial drugs such as ciprofloxacin. Where non-bacterial infections are going to be using anti-inflammatory drugs as well as prophylactic antibacterial agents. So, you guys know prophylactics is like before something happens. So, for instance, before you go in for maybe a surgery, they might give you some antibiotics, or one of the most common prophylactics is contraceptives, right? So condoms would be considered a prophylactic. So if you're not trying to get pregnant prophylactically, you protect yourself so that you won't necessarily get pregnant. And so this prophylactic antibacterial agents can be used if you know you're going into a situation that, like catheterization, right? That could potentially cause this. Um, Moving on to tumors, this is discussed at the end of page 518. You have benign prostatic hypertrophy, you have cancer of the prostate, and you also have cancer of the testes. So, specifically talking about benign prostatic hypertrophy, this occurs in up to 50% of men older than 65 years of age. So, this is pretty common. Okay. So, enlarged prostate. It's in regular terms instead of fancy terms. This is basically enlarged prostate. So, this is caused by hyperplasia, overgrowth, right? The bigness of the prostatic tissue. And also, since it's like the prostate is like a donut over the urethra, and so when you get prostatitis, right, and it's going to be inflaming that tissue, well, the donut's going to swell out as well as in. And so what's going to happen is it's going to end up compressing that urethra, and therefore it can cause urinary obstruction. Um, this is related also to an estrogen and testosterone imbalance, and this does not predispose one to prostate cancer, right, or prostatic carcinoma. It's just enlarged prostates can cause, urinary flow issues, and it's more uncomfortable than anything because you don't fully void your bladder if you're a male. This is a picture on page 519. It is figure 19.4, and this is of prostatic hyperplasia. And you can see that the tissue is kind of just swollen and red, right? Um, so again, you have an enlarged gland. And how you would diagnose this, you would have an enlarged gland that you can feel upon palpitation, so feeling on the digital, which is your finger rectal examination. So basically, the doctor is going to lube up, go up through the anus and push, and actually it would be like kind of this way up, right? And try to see if the tissue is going to be enlarged. And this can lead to frequent infections, and also continued obstruction can cause distended bladder, right, because you're not fully emptying, dilated ureters because you're not fully emptying, hydronephrosis because you're not fully deleting it, right, and then also renal failure if it's left untreated. So be a nag on your men and tell them, fix this, right? Um, so here are some complications of benign prostatic hypertrophy, and this is figure 19.5 on page 519 in your book. And so benign prostatic hypertrophy is abbreviated BPH, And you have the nodules, which would be from hyperplasia and hypertrophy, that are going to form on the inner part of the prostate. And then this, again, like that donut analogy, is going to compress on that urethra, and that can lead to obstruction of the flow of urine. And so then this is the difficulty initiating micturition and dribbling. So you have a hard time starting to pee, and then it kind of just dribbles because it's like over full, right? Because you're not fully voiding it. And again, that's going to lead to the incomplete emptying of the bladder, and therefore that increases the frequency that you have to pee because you're not fully emptying that bladder. It can lead to infection, which is called cystitis. Oh my God. This cystitis, that's not how you pronounce it, but my brain's like blanking right now. And then this can ascend to the kidneys, which would be polynephritis. You can also have that bladder distension because you're not fully emptying, and this can cause hydronephrosis, and that can also lead to kidney damage. Cystitis, there you go. See, sometimes you just got to get away and then come back. Cystitis, I knew that was my brain. All right, so again, signs and symptoms are going to be obstructed urinary flow, hesitancy in starting the flow, dribbling, decreased flow strength, because it's kind of like instead of having a full-blown open hose, it's like you turn the hose on just a little bit and it just kind of dribbles. Also, increased frequency and urgency, nocturia, and then dysuria can also occur if an infection is present. How do you treat it? Well, you can use drugs such as Advodart to slow the enlargement of the prostate. You can use smooth muscle relaxers such as Flomax. You can use a combination such as Proscar and Carduria, and this can reduce the progression of that enlargement of the tissue or the hypertrophy, or you can also do surgery. Moving on to cancers of the prostate, this is on page 519. This is the most common cancer in men of the age of over 50 years. And this is also the third leading cause of cancer death in men. And 1 in 6 men can be affected with prostate cancer. Most are adenocarcinomas that are going to arise near the surface of the gland, where the more undifferentiated the tumor, the more aggressive it can be. Okay. And many tumors are also androgen dependent. And so you just kind of got to keep an eye on things, right? You have both invasive and metastatic cancers that can occur, and some forms are highly aggressive, but others are not. 5 to 10% can be caused by inherited mutations, and other causes such as high androgen levels, increased insulin-like growth factors, as well as history of recurrent prostatitis can all cause to, potentially increase your chance of getting cancer of your prostate. Here is a picture of carcinoma of the prostate, and this is found on page 520, and this is figure 19.6. And so this specifically shows the carcinoma of the prostate that extends into the rectum and the urinary bladder. Okay, so get things checked and make sure that they don't go too crazy. Okay. Signs and symptoms of this are going to be a hard nodule that would be felt on the periphery of the gland. Also hesitancy in urination and decreased urine streams. You can also, again, because of the lack of full voiding, cause frequent urination and recurrent UTIs. How do you diagnose these? Well, by detecting serum markers like prostate-specific antigens or the PSA test, and this is the one that you hear about the most, right? And then you can also do prostatic acid phosphatases to check and see the serum levels of that. You can use ultrasounds, you can biopsies, and you can also do bone scans to detect metastases. Treatment is going to be surgery, right? So radical prostatectomy. So you're going to take out the whole prostate. Radiation can be either external or through the use of implanted pellets to target the specific prostate. If it's androgen sensitive cancer, then the orchiotomy is effective, and as well as the anti-testosterone drugs. So orchiotomy is chopping off the testicle, right? Think of Lance Armstrong, right? And also new chemotherapies are being studied right now in clinical trials. Moving on to the female reproductive system, this starts on page 521. So a little bit of anatomy first. The vulva, we have a couple different parts of it. We have the mons pubis, and this is where we have the adipose tissue in the hair that's going to cover the symphysis pubis. You have the labia majora and minora, and those are the outer and the inner folds of skin extending back and down from the mons pubis. You have your clitoris, and this is the basically our female's erectile tissue that's anterior in front of the urethra. And so, fun fact, when we are developing for the first couple, I think, weeks of life as we are an embryo, anatomically we're the same. And then, like for a male, the penis is going to extend out and form, or like that tissue is going to extend out and form a penis, whereas a female, ours like goes inside and forms a clitoris, right? The vagina is a muscular distensible canal that extends upward from the vulva to the cervix. So here is your anatomy. This is figure 19.8 on page 522. And basically you can just see that you have your labia majoris, the labia minoris, which is the inner ones. You have your clitoris, you have your urethra, you have your vagina, and you have your anus. So there are three holes, right? So you have your anal orifice, you have your vaginal orifice, and then you have your ureter orifice. So we have three as females. Right, and then you have your bladder, and then this is your uterus. So women that are pregnant always have to pee, right? And you can see now why. Because the baby would be growing here in the uterus, and it would be pushing down here on the bladder. So that's why you have to pee a lot when you are pregnant, right? And then also, you know, the why am I like blanking on all these terms today? So the colon, right, is also going to be here, and your exit is going to be through the anus. The uterus is a muscular organ within which fertilized ovums may implant and develop. The cervix is the opening into the uterus and the neck of the uterus. You have an external os, and this is the opening from the vagina, which is going to be filled with a thick mucus. And this is important because it prevents the vaginal flora from ascending into the uterus. So it's just kind of like a mucal membrane to keep external flora external, and then internal uterine flora internal. And then you have the external os, and then you have the fallopian tubes, which are also oviducts, and these are basically tubes from the ovaries to the uterus. Okay. The ovaries are going to produce ova and estrogen, and also progesterone hormones. Females also, well, males do, but our breasts develop. So our breasts have glands that produce colostrum and milk that are necessary for a newborn. And also there's a lot of fat tissue, or the adipose tissue, in the breasts. Here is a picture of the female breast, and this is on page 525. And over here you have a sagittal section of a lactating breast. And so it says, notice the glandular structures are anchored to the overlying skin and to the pectoral muscles by the supraspensatory ligaments of Cooper. Okay. These are those suspensory ligaments. And then each lobule of glandular tissue is drained by a lactiferous duct that eventually opens out through the nipple. And then here is the anterior view of a lactating breast, and the overlying skin and connective tissue have been removed from the medial side to show the internal structure of the breast and the underlying skeletal muscle. In non-lactating breasts, the glandular tissue is much less prominent, and adipose tissue makes up most of the breast. So, what about hormones and the menstrual cycle? The cycle may be anywhere between 21 and 45 days. It's dependent on each woman. Each woman's different, and it can vary between month, right? And the cycle consists of menstruation, and this would be from days 1 to 5. You have endometrial proliferation and the production of estrogen. And again, this is the part that's going to vary with between each female and also between each month. You also have maturation of the ovarian follicle. And then you have the release of luteinizing hormone, and this is what's going to cause the actual ovulation. So with the menstrual cycle itself, the follicle is going to mature into the corpus luteum, and this is what's going to produce progesterone. And then you have the vascularization of the endometrium, and occurs because it's done in preparation for implantation of the egg. And so this would be about 12 to 14 days prior to the onset of your next menstrual cycle. And if implantation does not occur, i.e. you don't get pregnant, then the corpus luteum atrophies, so it gets big and it actually ends up exploding, right? And then you have your uterine muscles that are going to contract, and this is going to lead to ischemia of that uterine tissue, which is A-OK. And then the endometrium is going to degenerate, and therefore we can expel it from our body through a menstrual period. Here is the overview of the female reproductive cycle, and this is on figure 19.9 on page 524. And so there's a lot of information on this slide and in this figure. And so this is specifically looking at the events that are occurring in the ovary. So you have your follicular maturation, and then when it gets to the point where it's mature enough, you're going to have ovulation. So then the egg is going to be going outside of the follicle. And then the kind of casing or the housing is going to kind of grow and atrophy, right? And it goes to the point of the corpus luteum, and then your body just degrades it, right? And it breaks it down. And so this is kind of just, this is how the egg is going to be matured and then ovulate, and then the housing breaks down. And then looking at the endometrial lining, so this is the lining of the uterus, you would have, this is at like the tail end of the last menstrual cycle. So you're shedding all of the endometrial linings, okay? And then you have a little bit of a period here where you have pro-ovulatory. So like you're building up the endometrial wall. And then for the ovulation, potentially if you did have an implanted pregnancy, right, then the wall would continue to thicken and be able to support the developing embryo. But if you ovulate but you don't get fertilized, right, then it keeps growing, and then your body says, oh, okay, not this month, let's shed it and start again. And so that shedding is going to be your menses, okay? And then down here, you can look at the different hormone levels. So for the hormone levels, this is the follicle stimulating hormone. So it makes sense that it kind of amps up a little bit right as we're growing. And then it peaks right as we're ovulating. And then it goes down afterwards. Your estrogen levels, they're going to just kind of be steady eddy. And then right as we are ovulating, they peak. Okay. And then after the ovulation, they go back down. Luteinizing hormone, same thing. It's going to peak right after the ovulation and then go back down if it doesn't need to stay elevated. And then progesterone levels, same kind of a thing, right? So they're going to be low to begin with, and then as we're getting ready to shed, then the progesterone levels as well as the FSH levels will increase, and it's like, oh, okay, well, the uterus isn't pregnant, no embryo needs to implant, so let's shed everything and start all over again. So this is a very cool summary figure. So talking about female reproductive disorders, we will start off with pelvic inflammatory disease, and this is where we have an infection of the uterus, the fallopian tubes, and or the ovaries. And this may be acute or it can be chronic. And the infection also usually originates from an ascending infection in the lower reproductive tract, and this may occur because of bacteremia. And most infections arise from sexually transmitted diseases or non-sterile abortions or childbirth. This is a picture of pelvic inflammatory disease, or PID, and this is figure 19.13, and this is on page 529 in your book. So up here in A, you have the spread of the infection, right? So this is where you have peritonitis, and then the infection is going to spread into the peritoneal cavity, and then it can spread and not be very fun. And then this would be the uterus down here is perforated by an IUD, okay, an intrauterine device, which you can see over here, the adhesions that are forming of it. And then this can lead to localized inflammation of peritoneal cavity and omentum forming adhesions around the IUD. And so IUDs are either copper, or they can be hormone embedded plastic type things like this, right? Like I think, was it Moderna? No, that's a shot right now in COVID. There's a couple different, there's copper IUDs, there's a whole bunch of different ones, and sometimes they can migrate or embed into the tissue, right? And so then you'd have to have them potentially surgically removed. So there's pros and cons to every type of contraceptive, and that would be one of the cons of an IUD. So the scarring of the tubes can increase the risk of infertility as well as ectopic pregnancies. And what ectopic pregnancies are is when the egg is released from the ovary and it travels down the fallopian tubes in its journey to the uterus to implant. A sperm can travel up through the uterus and go into either of the fallopian tubes. And then if it causes some fertilization, then the egg's like, oh, yay, I'm fertilized, let's embed. And it embeds in the fallopian tubes instead of in the uterine tissue. And it's potentially lethal, right? And so you need to really be careful of ectopic pregnancies. If you have a lot of pain that's unexplained, I mean, obviously your doctor would be the one to diagnose that, right? You also have potential acute complications such as peritonitis, pelvic abscesses, as well as septic shock that can occur. With pelvic inflammatory disease, pelvic pain is usually a first sign, as well as fever, guarding, nausea and vomiting, leukocytosis, as well as a purulent discharge that can also be present. And you also have treatment that usually requires aggressive antibiotic therapy in the hospital to get these under control. Moving on to malignant tumors. You have either carcinoma of the breast, or you have carcinoma of the cervix, or carcinoma of the uterus, as well as ovarian cancer. And these are discussed on page 532 of your book. With carcinoma of the breast, the incidence increases after about 20 years of age. Most cases in women occur between the ages of 50 and 69 years. Most tumors are unilateral, so one-sided, not bilateral, both sides. Earlier onset can be associated with more aggressive growth, and there are also different types of the carcinomas, and most arrive from ductal epithelial cells, where metastases can occur via lymph nodes early in the course of the disease. And we also have the presence of estrogen or progesterone receptors on the tumor cells that can influence the treatment, and everybody's individual, so everybody will have an individualized treatment and therapy. Some predisposing factors of the breast cancer would be a first-degree relative with the disease, a strong genetic predisposition, i.e. the presence of BRCA1 and BRCA2 genes in your body, the longer and higher exposure to estrogens, so some people don't like the higher estrogen birth controls for this reason. A nalperis or a late first pregnancy can also predispose you to that. A lack of exercise, smoking, a high-fat diet, radiation therapy that's used in the chest, as well as cancer of the uterus, ovaries, and or pancreas. Signs and symptoms would be a change that's detected on the mammogram. An initial sign would be a single, small, hard, painless nodule. Later signs can be distortion of the breast tissue, dimpled skin, as well as discharge from the nipple, and the ultrasound or a needle biopsy can confirm the diagnosis. For the course of breast cancer, metastases occurs by the time the tumor is 1 to 2 centimeters in diameter. The axillary lymph node involvement can occur as well, and secondary tumors are often located in the bone, lung, brain, and the liver. Here is a picture of metastatic breast cancer, and let me find where this one is in your book. Let me pause you for a second. Okay, I can't find this exact figure in your book, but basically what this is showing is how things spread. And so basically, if you have the primary cancer and then a cell breaks off, it can hijack the blood system, right? The circulatory system, hop in there, and then it can spread to other parts of your body, such as your lungs, right? So it could start in your breast. Once it gets into the blood system or the lymphatic system, right? Then it can spread to the other parts of your body, and that's what the metastatic would be. It would be the spreading. Okay. Here is a picture of invasive carcinoma of the breast. And so you can see that there is a lot of like granular tissue, right? And so it's just very scary. Like I told you guys from the very beginning, the two things that really scare me are viruses and cancer, right? So you can see ovarian cysts on figure 915. Let's see, uterine fibroids on page 531. So they must have updated the slides from, they haven't updated the slides from the book. Anyway, so you can see the invasiveness of the carcinoma of the breast. So how do we treat this? Well, surgery may be either a lumpectomy or a removal of the whole breast. The lymph nodes may be removed depending on the stage of the disease, and the tissue biopsy will determine the presence of the specific growth factors, and then we'll design a drug treatment and chemotherapy to target that specific cell, right? Radiation therapy may also be done before or after surgery to help reduce the spread in size. You also have drug therapies that can be used. And so you can use hormone blocking agents such as tamoxifen, Avista, and tromelophin. And you also have estrogen receptor blockers. And these can be Faslodex, and this is going to block your estrogen receptors on the cancer cells, as well as this. It will help to signal the cell to help destroy the receptors. You can have drugs that are inhibiting the estrogen production, such as arimidex, Ferrima, and amorosacin. I am not a pharmacologist. It is my minor, but hey, I don't know how they like name these drugs. It's so funny. All right, there are also a lot of other different drugs that can treat these, and so you can see some of these are listed on page 533. And so you can do combinations. You can do where you have targeting growth factor protein, and it can be used in combination with chemo. Ibrance is used in women with advanced hormone receptor positive breast cancer. Afinitor is going to target the pathway that plays a role in the growth of the cancer cells. And then women with stage 3 or 4 breast cancer may receive Avrostin to reduce the growth of the blood vessels in secondary tumors. Moving on to the last topic for the last 12 slides of this whole class, you guys. You made it. You made it. Now we get to scare you with STDs and STIs. Okay, so first of all, they're really common. So take away the stigma, right? So about 1 in 3 people nowadays in 2021 have an STI or an STD. So most of them are treatable, and I mean, obviously don't go out and try to get them, but it like crap happens, guys. So be very careful, use protection, try not to obviously get them, but don't knock people that necessarily got them, because sometimes it's not their fault, right? So I'm always the advocate for everyone else. So, but with our STDs, you have bacterial infections such as chlamydia, gonorrhea, and syphilis. You also have viral infections such as herpes or the genital warts. And you can also have protozoan infections, which would be trichomonas. specifically talking about your bacterial infections and chlamydia. This is considered one of the most common STDs. The cause is chlamydia trachomitis, and in males, it causes urethritis and epididymitis. And so the symptoms include dysuria, itching, and white discharge from the penis, and also painful swollen scrotum, and usually this is unilateral with fever, and it can have inguinal lymph nodes that are swollen. And in females, that's often asymptomatic until the PID, or infertility, pelvic inflammatory disease, or infertility develops. And newborns may be infected during birth because they go through the birth canal unless it's a cesarean section, and they can pick up a bacteria as they're going through. Gonorrhea is caused by Neisseria gonorrhoeae, and many strains have become resistant to penicillin and tetracycline. And so there we had to come up with new creative drugs to treat these things. In males, the most common site is urethra, which is inflamed, and some males are asymptomatic. They don't know that they have it, and so this is how they spread it. And in females, they are frequently asymptomatic. Again, you have the pelvic inflammatory disease and infertility, and these are serious complications that can occur from gonorrhea. Gonorrhea may infect the eyes of the newborn, again, because you're pushing through the vaginal canal, and this can cause irreversible damage and blindness, and this may spread systemically to cause septic arthritis. So obviously in the United States, there's a squirrel outside my window, that we're really fortunate because we can kind of test for these and monitor them. So it's not as detrimental as it would be in like some third world countries, right? Here is a table of different STDs or STIs, and this is on page 539. This is table 19.1. So it tells you the infection, the cause, signs, complications, and treatment and care. So this would be one to bookmark, okay, because it's nice and summarizing. So now for the pictures, gross you guys out, not gross you guys out, but I love teaching this in person because it's fun to show pictures. Okay, so this is the acute epididymitis, which is caused by gonococcal infection. So this is figure 19.21 on page 540. And you can see that there is a lesion here on the testicle that is developing. With syphilis, this is caused by Tryponium pallidum, which is a spirochete. The primary stage is going to be where you have the presence of a canker at the site of the infection. This is going to be in the genital region or the anus, or it can be also in the oral cavity. These are painless and firm ulcerated nodules, and they occur about 3 weeks after exposure, and the lesion will heal on its own, but the client is still contagious. So this would be a picture of one of those cankers. It looks like it's on the tip of the penis. Looks like the head of the penis there, so that would be on the shaft of the penis. And this is figure 19.22. And this shows a scanning electron micrograph showing the thin spirals of the causative factor that are adjacent to the erythrocytes. And then down here is the penile syphilitic canker, and this is again going to be a painless pupule or papule with central ulceration, right? And at the inoculation site on the penis. You have a secondary stage, and if it's left untreated, it causes flu-like illnesses to occur with widespread symmetrical rash. And if it's self-limited, but the client remains contagious, people still have to be very careful to not spread it, right? The latent stage may persist for many years, and transmission may occur. Then you also have tertiary syphilis, and this is where we have irreversible changes that can occur. And this is where you have gumas that can occur in organs and major blood vessels, as well as it can cause dementia, blindness, and motor disabilities. Back in the day, with I think of the old West days and stuff, like syphilis was incredibly common because A, they didn't have penicillin to treat it, and B, they just didn't. I don't want to say they didn't know better, but the times were different back then. And so if it was left untreated, then, people could go blind right? They would kind of go crazy, have the dementia, and you would have motor disabilities. And so they didn't realize that it was because of tertiary syphilis until many years later. But so many things could have been cured and fixed by just a shot of penicillin back in the days, right? So be thankful we live in 2021. Um, so the organism can also be transmitted to the fetus in utero. A baby born with tertiary syphilis changes that are not reversible. And so if you do have it, you want to make sure to treat it so that it doesn't get passed on to a baby. The treatment is usually antimicrobial drugs. And because we have an increase in antibiotic resistant strains, this is causing an increase in prevalence of syphilis. A couple of the other ones that we're going to talk about are your viral infections, such as genital herpes or the herpes simplex virus. This can be caused by herpes simplex virus 2 or 1. And HSV1 is possible with oral sex. And there are lesions that are similar to HSV1. There are recurrent outbreaks of blister-like vesicles on the genitalia, and these are preceded by tingling or an itching sensation, and the lesions are extremely painful. After the acute stage, the virus migrates back to the dorsal root ganglion, and infectivity is greater when the symptoms are present. So if you're having lesions, obviously that's very, very infective, but you can also infect during like shedding and other things. Here is a picture of genital herpes on the vagina and the penis. And so this would be on page 541, figure 19.23. And so this would be the herpes simplex virus in the cervical specimen. And the infected cervical cells stain brown when you're going to look at them in the cells. But you can see like it looks like the white lesions on the vulva and up towards the clitoris, right? And then on the penis here, this is genital herpes in the female and male, so note the blisters and the ulcerations. So again, the blisters and ulcerations you can see on both the penis as well as on the vagina. Reactivation is common and it may be associated with stress, illness, as well as menstruation. And antiviral drugs are used for treatments and prevention of transmission, and infections are considered lifelong. All right, so that wraps up the chapter and therefore this class. Thank you guys for being a wonderful class, and we will see you in lecture. Thanks. Bye-bye.